All right, guys, shall we start? So today was an important quiz. Today was a retina quiz and other questions. So shall we start? Okay, so first of all, those of you who joined live, good evening. I missed you yesterday, beta. I was looking for you. Good evening. Okay, so we will start. One second, let me just look at the questions. Mm. All right. So question number one. Okay. So question number one. The opening of the Clockett's canal in front of the optic disc is called. I know this was a bouncer. Okay, you always get bouncers, no, in exams. So it's like that. But it can be answered based on. All right. Okay, no problem, Yu-chan. But anyway, you could have watched it later too. All right. So this question on vitreous, the opening of the Clockett's canal in front of the optic disc is called. So I'll tell you how to do this question. Okay, based on what we know. So one is this canal of Petit. See, the canal of Petit actually was a bouncer when it was asked 2 years ago in INICET. Okay, and we know that is an interzonular space. Canal of Petit and Canal of Hanover. So there is an option Canal of Petit, option A, and on option C you have Canal of Hanover. So both those are ruled out. Both these are ruled out because those are close to those are something related to the zonules. Yes. Whereas my question asks, what is the opening of the Clockett's canal in front of the optic disc? So this is posterior in front of your optic nerve. So definitely not Canal of Petit, not Canal of Hanover. So two options ruled out. So now we are left with Martigiani space and Berger's space or the Berger's space. See, Berger's space I've taught you. It is the space behind the lens, between the lens and the vitreous, the retrolental space of Berger. Yeah. So you know Berger's space. So the only option left is Canal of Martigiani. So you all know what is Clockett's canal. Clockett's canal is a remnant of the primary vitreous, that is a hyaloid artery which has regressed. Hyaloid artery's primary function is to supply blood to the lens, fetal lens, because adult lens is avascular. So once the baby is born, that hyaloid artery has to regress, and in the space of that hyaloid artery there is a empty space in the vitreous gel. So where did it actually run the hyaloid artery? From the optic disc to the posterior pole of the lens. So you have towards the optic disc there is a funnel like opening, it's just over the optic disc margin. Yeah, so that empty space here is of the Clockett's canal is area or space of Martigiani. Okay, so that was the first question. Still doable. Okay, although it looked like a bouncer. That is why if you had done the previous question on vitreous anatomy, which was asked in INICET a couple of years ago, and you knew that Canal of Petit and Canal of Hanover, this was very easy. Okay, and thank you all, those of you, in spite of your Saturday commitments, you still arrived very promptly for this session. Good. Okay, so the next question is, there is a fundus image and the given fundus image is typical of. So the image is this. Yeah. So the image is this, because this is how you will get in exams. In exams you will not get very zoomed out images, but now I am zooming out for you. Okay. Now what you see in this image is full of blood. Yeah, full of blood. Now even if you don't have much clarity of, you're not able to see much, but still let's go to the options. The given fundus image is typical of central retinal artery occlusion. No, yeah. See, central retinal artery occlusion, we'll have a milky white retinal edema and then the cherry red spot. Not red everywhere like a splash tomato appearance. That is a splash tomato appearance, no? This is a splash tomato appearance. It's like you've just splashed tomato on the fundus, on the retina. Blood everywhere. So much of retinal hemorrhages. Yes, so definitely not central retinal artery occlusion. One ruled out. Non-proliferative diabetic retinopathy. In my previous retina quiz, I discussed NPDR image. There's just a few red dots and yellow dots. It's like you've got microaneurysms, small red dots, a little bigger red dots like blotches, the dot blot hemorrhages. Then you have cotton wool spots like yellowish splashes, and very sparkly yellow dots, hard exuded. So you've got just red and yellow dots, not blood splashed everywhere. So NPDR also ruled out. So two options ruled out. Retinitis pigmentosa. This also I taught you just before the INI-CT exam. I told you look for the black corpuscles, or what I call the kalapuchis. The black insects. Kala is black and insects crawling from the periphery, mid-periphery. So nothing black about this picture at all. Yes, only the mental blackout when you look at the fundus image, right? So even if you rule out, you'll arrive with the answer, which is central retinal vein occlusion. For those of you who joined late, central retinal vein occlusion, CRVO, is going to look like this. Blood everywhere. It's like water everywhere, not a drop to drink. Blood everywhere. Okay, and we are not vampires, so we're not drinking the blood either. Yeah, so all of you, Pakka brain box, it has gone in. CRVO, central retinal vein occlusion. Yes, so go to my previous video. I've actually put up in the Instagram that beautiful retinitis pigmentosa with the insects crawling in. Look at that previous YouTube retina discussion. We've done NPDR discussion. Yes, CRAO in one of the coming sessions. I'll explain that to you. Okay, so the answer here is central retinal vein occlusion. Now I can make your life tricky by giving you a branch retinal vein occlusion. See, branch retinal vein occlusion is only one area there will be redness, not like this one, no, where the entire fundus is full of hemorrhages. So branch retinal venous occlusion would be usually a superotemporal location. So where are we seeing the optic disc here? Yeah, the optic disc is edematous. It is here. So mostly it is a superotemporal. So you will have that branch, the redness only in this quadrant, superotemporal quadrant. Okay, if it were to be BRVO. Yeah, so that's the only extra way I can complicate your life. Nothing more than that. Okay, next comes the retinal histology picture, and I've asked you to identify the marked layer. Okay, the marked layer. Now it's very simple, very simple. Okay, so it's here. Okay, let's do the ruling out. Outer nuclear layer of rods and cones, inner nuclear layer, inner plexiform layer. So two layers I can simply rule out by looking at where it is marked. The marking is in a layer which is full of cells and nuclei. Okay, so it is definitely not a plexiform layer. Plexiform layer has only axons. Okay, so ruled out. So whatever, whether it was, I don't remember now whether it was an inner plexiform or an outer plexiform, that is ruled out. Okay, and layer of rods and cones. When I say layer of rods and cones, I am talking about where the outer segments with the pigments, the visual pigments are present, not where the nucleus of the photoreceptors are present. So the moment this is marked, the layer of rods and cones or the layer of photoreceptors is ruled out, a plexiform layer is ruled out. Okay, so that is already ruled out. Yeah, so we've got only two options now. So layer of rods and cones ruled out, inner plexiform is ruled out. So you've got two options now. One is outer nuclear layer and another is inner nuclear layer. Okay, so now it's nuclei, for damn sure it's a nuclear layer. But now whether it is outer nuclear layer or inner nuclear layer. Now look at this. This one, you see the capillaries here. So this is the choriocapillaris. This one, okay, just the border. Okay, so that is the choroid. And you got a layer of RPE. And the outer segment here is very densely pigmented and is actually a beautiful histology. Normally you don't get such densely pigmented, stained outer segment layer. It's in fact in continuity with the RPE. Almost looks like in continuity with the RPE. Okay, so you got the RPE and the outer segments, the inner segments. This is the outer nuclear layer, because see, I see a layer of, I'm sorry, one second. Let me zoom it out. Okay, so this is the outer segment, the inner segment. This is the outer nuclear layer. This is where the nuclei of the rods and cones are present. Then we've got the outer plexiform layer, also known as the Henle's layer, OPL, Henle's layer, inner nuclear layer, inner plexiform layer, ganglion cell layer. Then you got your RNFL and your internal limiting membrane. That's probably the vitreous. All right, vitreous would not have been there because it's not part of the stream. Yes, so this is your inner nuclear layer where you have the cell bodies with the nuclei of bipolar cells, horizontal cells, amacrine cells, Muller cells. Okay, so that's why an abundance of it. Okay, so always, now when you have a doubt whether which is, ma'am, is this outer or inner, how do I remember that? See, choroid is outer to the retina. Retina is the inner coat. Sclera is the outermost coat. Choroid is the middle. But with respect to the retina, the choroid is the outer coat, right? And RPE is the outermost layer of the retina. So you're coming from outer to inner. So outer nuclear layer, inner nuclear layer, the ganglion cell layer. Is that clear? And what are all the cells that are present in the inner nuclear layer? You repeat after me. I know it's very silly, but remember. You got the bipolar cells, the horizontal cells, the amacrine cells. Like I say, the modulatory cells are the HARP cells, and the housekeeping or the nurse cell, that is your Muller cell. All these are present in the inner nuclear layer. So the answer is inner nuclear layer. You will not forget it. Oreva Yuchan. Okay. You should ping me sometime, okay, on WhatsApp and tell me your real name. I will not reveal it here, but yes, I would love to know your real name. Alright. Outer blood retinal barrier is at the level of, आई एम गेटिंग क्यूटर एवरी डे. हु इज दिस? अरे तुम्हारा नाम बांग्ला में लिखा हुआ है तो इसलिए मेरे को समझ में नहीं आ रहा है, बट वॉट एवर आई एम टीचिंग ऑल ना. So when I teach you, I feel very happy. All right. So outer blood retinal barrier is at the level of, see, outer blood retinal barrier, okay, it's at the level of the outermost layer of the retina, which is the outermost layer of the retina, retinal pigment epithelium. So RPE के बीच में, between the RPE cells, you have tight junctions. Okay, so that we'll go back to that. We'll use that diagram so that I can, the histology picture, so that you'll understand. So you got this choriocapillaries. So I don't want this blood or the fluid from here to seep into my retina, because I've got a potential space here, subretinal space between my RPE and the inner 9 layers, my NSR. So I don't want fluid or blood to seep in. So I need tight junctions. So obviously I will need tight junctions in my compound wall, my outermost layer, RPE. Okay. So BRB, outer BRB at the level of RPE. So what were the options? We had retinal capillary endothelium, and some of you have chosen that, my dear bache. The inner blood retinal barrier is at the level of the retinal capillary endothelium, tight junctions between the endothelial cells of the capillaries. Okay, outer BRB is at the level of RPE, right? And Muller cells, why it wasn't the option? Because if you know a lot, then you get a little confused. Muller cells also do contribute, but to the inner blood retinal barrier. It's like the housemaid ना, जो बाई है घर की, तो वो तो contribute करेगी ना. She is going to contribute to the inner blood retinal barrier. Yeah, yes. Like they say, when Saif Ali Khan was, assaulted, some maid came to his rescue, some bullshit that they said. So you need the maids to give you protection also. Outer you need a security guard, and inside also you need some maid to give you security. Okay, it's something like that. Okay, now I am saying maid because the nurse cell is your Muller cell. M for M, the maid. Okay, all right. Now the next question: which of the following is a long-acting VEGF? See, the options were bevacizumab, ranibizumab, ipilimumab. Yeah, ipilimumab is not even anti-VEGF. Okay, so that is already ruled out. And then you got brolucizumab. I remember in one of the sessions that I did for you, one of these YouTube live sessions, somebody asked me randomly, I think it was the last retina quiz or the FAQs, they asked me, ma'am, what are the latest anti-VEGFs? And I told you, the longest acting, one of the long acting anti-VEGFs is brolucizumab. Okay, brolucizumab is long acting. Yeah, so I'll tell you a very easy way to remember. So there is a bro and Lucy. Lucy has brozoned him. Okay, but he still is persistent. Okay, because he thinks he's persistent, he will get into the zone of whatever his desire is. Okay, so brolucizumab is the long-acting anti-VEGF. So you can space out the anti-VEGF injection for a longer time. Yeah, so it's a Paginax injection that we give. So I hope in your exams you will not give Paginax, because this time when we saw a lot of short forms were there in the exam. So when clinicians set up question papers, they just give the trade name. Okay, so next time maybe instead of Brolucizumab, you're looking for Brolucizumab and they've given you Paginax. Okay, all right. Okay, good, Yucham, you will not forget. Okay, great. All right, now the next question on FFA, silent choroid is seen in. FFA is fundus fluorescein angiography. Now this is actually a previous year question. Silent choroid, or it's also known as dark choroid, because normally choroid will give you a blotchy background in your FFA. If you see, there will be a background fluorescence, although it is very dull, but completely black, that is dark choroid or silent choroid, which is typical of Stargardt's disease. Okay, so again I'll tell you a very easy way to remember. If you want to look at the stars, you want a clear dark sky, you don't want clouds in between. See, normally choroidal fluorescence will be like cloudy. Okay, so it's like you're seeing the stars in between the clouds at night. But when I want to do stargazing. Stargazing ke liye you need clear dark sky. Then your stars will twinkle. So remember that way, your dark choroid or your silent choroid on FFA, fundus fluorescein angiography, is seen in case of Stargardt's disease. Okay, there is no other option for this. Okay, all right. So moving to the next question, vitreous hemorrhage presents as. Guys, this is very simple. See, suddenly in your path of light, your vitreous is a media. Media means path of light, there's bleeding. So there is going to be a sudden loss of vision. Okay, a sudden loss of vision because something is blocking your path of light. And vitreous does not have pain fibers. Vitreous, retina, choroid, they do not have pain fibers. So anything in the vitreous, anything in the retina, anything of the choroid, they will be absolutely painless. So sudden painless loss of vision. Okay, so very, very easy, sudden painless loss of vision, vitreous hemorrhage. Yeah. Okay, but the only thing is the options were a little lengthy to read, so you had to, go through the trauma of reading through sudden painful loss of vision, slow progressive painful loss of vision, slow progressive painless loss of vision, and by that time you're like, yeah, dude, I'll come back, I'll revisit this question. If it were your actual exam, you'll be like, this is very difficult, I'll come back. Okay, because it was lengthier, the options were lengthier. Okay. Now, the next question, which of the following is a finding of hypertensive choroidopathy? See, nobody talks about choroidopathy. We always talk about retinopathy, but hypertensive choroidopathy is actually very, very important, because when you have acute elevations of blood pressure, sudden spike, it's not a retinopathy that actually manifests. There's a lot of things that manifest the choroid, okay, because choroid is very, very sensitive. Choroid is extremely sensitive, more than retina. So we do have choroidal findings, especially in acute IOP spike. Sorry, I'm saying IOP, BP spikes, blood pressure spikes. So cotton wool spots is a RNFL infarct. So it is not in choroid. It's not at the level of the choroid. See, if you had simply applied your mind, just this concept that it's a choroidopathy ka kuch puch rahe hain. They're asking something about choroidopathy. And I am seeing cotton wool spots, which is probably a retinal finding. Silver wiring of retinal arterioles. Retinal arterioles. We're not talking about choriocapillaries here. So again, that is in retinopathy, not in choroidopathy. And it's a chronic finding. Okay, when you have a chronic elevation of blood pressure, that is when you're going to have this arteriolosclerosis, and thereby your copper wiring, and in later stages silver wiring. Okay, so that is not. And another option was bonnet sign. See, bonnet sign is at the AV crossing. It's at the arteriovenous crossing changes. So again, that is to do with retinopathy, not choroidopathy. So Elschnick spots are basically, you see some small whitish yellowish spots beneath the retina. So when we see the fundus, we are seeing it in the stereoptic view, with the 3D, when you're using your indirect ophthalmoscope, or especially when you're seeing with your lenses on the 90D on slit lamp, you get a nice stereopsis, and you'll know the depth of the lesion. Okay, so these are actually choroidal infarcts. Okay, choroidal infarcts, and because of the there will be actually what we call this RPE ka infarcts. That's what, okay. So choroidal infarcts which will result in RPE infarcts. So we do have acute Elschnick spots and chronic Elschnick spots that I've discussed in the videos. Now Elschnick spot is very different from Elschnick pearl. Okay, Elschnick pearl, all of you know. Elschnick pearl is your after cataract or your PCO, posterior capsular opacification. That is Elschnick pearl. This is Elschnick spot. Okay, Elschnick spot is seen, again, please write it down because probably it's new for you. Elschnick's, it's not new for an ophthalmologist, but yes, for you it might be new. So Elschnick spot is seen in hypertensive choroidopathy. Okay, hypertensive choroidopathy, and it is an acute event. All right, now C-fan neovascularization, guys, it's a very standard question right from the days I was a student. C-fan neovascularization is seen in sickle cell retinopathy. I'll teach you in one of the days. Okay, the fundus. Definitely not retinopathy of prematurity. You've definitely not learnt in PDR or NPDR, so that is ruled out. And occult CNVM, no, occult choroidal neovascular membrane. I know it sounded very fancy and kind of not even fancy. It sounded very exotic when you heard that word. That option, occult choroidal neovascular membrane, and some of you actually went for that mind game. No, it is sickle cell retinopathy. Okay, so sickle cell retinopathy, very, very typical C-fan neovascularization. Okay, and the next question, an 8-month-old. Okay, so there was a fundus image. Yeah, so there was a fundus image. This is the same fundus image we had in the previous retina quiz. Okay, and I'm not giving you the diagnosis because the moment you see a fundus image, you're already flummoxed. You're like, okay, I'm not going to answer this question. Okay, but read the question, and that now this question is long. An 8-month-old baby presented with leukocoria in the right eye. Fundus exam showed retinoblastoma. So there's no point to worry about this question at all. They've already given you the diagnosis. Okay, so that fundus image was basically now to put stress into you. Just examiner's way of filtering out people who cannot handle stress. Okay, so they say fundus exam showed retinoblastoma as seen in the image. Great. Left eye was normal. Very good. It was decided to administer intraarterial chemotherapy. So that also they've decided. They've decided to give IAC, intraarterial chemotherapy. So what is the question now? The following drugs are given as IAC except. So you just need to know the regimen that is used in intraarterial chemotherapy. So intraarterial chemotherapy is where you cannulate from the femoral vein and reach the ophthalmic artery and directly push the chemo drugs into the ophthalmic artery. And that is something the ophthalmologist does not do. That is something the interventional radiologist does in coordination with the ophthalmologist, with the ocular oncologist. That's it. Yeah. So what are the drugs that we give? I've told you, remember the MTC, or you are very fond Bangla people who are watching, you can remember your TMC. Okay. Okay, I don't want to bring politics here, but this is just for you to remember. Okay, so MTC is easier for me basically because I'm from Chennai and I grew up in the days when the we used to call it Madras Transport Corporation, although it was PTC, Palwan Transport Corporation, so something like Madras Transport Corporation, or let's say Pan India, we can remember Trinamool Congress, some Congress. Okay, so Trinamool Congress, TMC. So T, topotecan, M, melphalan, C, carboplatin. Okay, so topotecan, melphalan and carboplatin. And please remember, it is carboplatin and not cisplatin because we're talking about retinoblastoma. RB should be there because many of you make that mistake. Cisplatin, it's carboplatin. Okay, so TMC, topotecan, melphalan and carboplatin. Okay, now this is intraarterial, which is way different from what we give intravenous, which is a systemic chemotherapy. Intravenous is, as you all know, it is VEC regimen, which is vincristine, etoposide and carboplatin. Is that clear? Yeah. So generally when we say treatment of choice for retinoblastoma, it is that VEC regimen which is the treatment of choice. The systemic, that is intravenous chemotherapy. Specific circumstances we do give this IAC, intraarterial chemotherapy, where we give TMC, topotecan, melphalan and carboplatin. Okay. So we have come to the end of the 10th question. All right. Okay. So any other questions in retina, guys? I kind of have included vitreous also this time, because vitreous felt really like an often always, saying, okay, you give too much of importance to retina, you don't give importance to vitreous. So this time we had two questions from vitreous, and the rest were kind of balanced, all kind of topics from retina. If you have any doubts, just let me know in the comments, and you can give me a hearts. I love hearts. Little hearts, not big hearts. Big hearts is too big to handle. All right. Any other questions from retina? Something you have? Any doubts? Okay. And please share the Telegram academic group link with more of your friends. It's much nicer when you have a lot of students taking the test, so that you know where you stand. Okay, so please do share the Telegram group link with your friends. And today we have a post on Instagram. There's one is a question post where you can comment your answers. Let me see how many of you will answer. That is pretty easy, that one. Okay, it's an external eye picture on Instagram. And then also I posted something which is good for your memory. It's a memory trick. So don't just watch that, apply it in your life for that. All right, any other questions? अरे तुम्हारा नाम क्या है बेटा, जो बांग्ला में लिखा हुआ है आपका नाम? आप इंग्लिश में एक बार हमारे लिए ट्रांसलेट करके लिख सकते हैं क्या? बिकॉज मेरे को हिंदी आती है बट बांग्ला तो नहीं आती है. आई नो बांग्ला इट्स सो नाइस, इट्स ब्यूटिफुल व्हेन इट इज रिटन एंड स्पोकन, but unfortunately I don't know your name. Okay, any other questions regarding retina or vitreous? So today something new you learned about vitreous, about area of Martegiani. Okay. Okay, ma'am, I wanted to know if बेटा मुझे नहीं पता. Whatever drugs I have told you, those are the standard drugs we use in the standard treatment. It's become that's the SOP we follow. Okay, and वो हर जगह we follow that. Okay, internationally and here. See, I got trained in University of Michigan. There also we follow this, and even back here, this is what we follow in institutes. Because only in institutes we can use these drugs, not as a standalone ophthalmologist. So write it down, okay? It's definitely there in my notes. मेरे notes में दिया हुआ है. Hey, good evening, Sarthak. Nice to see you. Yeah, I'm doing well, beta. Doing very good. You can take my OSM book. It's written there also. And my Josh Clinic book. I think we are not promoting it as much. It's there. Okay. So you can look up on Insta how to order, or you can WhatsApp me for the OSM book and the Josh Clinic book. What is Sarthak telling me? This much Bengali I know, ma'am. Ami, what is that? I only know Tika Che. Sarthak, you always bring a big smile to me, yaar, really. Okay. Got it? All right. तो सार्थक, I was thinking you're a Odia guy. तो बांग्ला है क्या? बंगाली? चलो whatever यार, let's not get into all this linguistic stuff. तो कोई कुछ रेटिना में डाउट है बच्चे? Okay, so you can WhatsApp me for the books. Oh, yeah, I know you are Bengali, but we don't know your name. I'm just trying to find out your name, so that I can, like Sarthak ko, I call him out during the sessions. चलो जो भी है. Okay, बच्चे, I don't think any more questions on retina is coming up. We're just prolonging the session and you're having masti at my expense. Okay, so what is the topic for tomorrow? Tomorrow's quiz. आप लोग क्विज ले रहे हो या बस यहाँ आके मस्ती करते हो? Tomorrow is glaucoma. Okay, so 6 p.m. is the glaucoma quiz and I will see you here at 9 p.m. Okay, chalo guys, bye all of you. Yeah, good day, good night. Oh, Sarthak aa gaya to itne hearts, my little boy. Thank you so much, Sarthak. That's wonderful. He knows it, no? You know कितने हार्ट्स मुझे चाहिए, बहुत सारा, ढेर सारा. All right, good. Okay, bye guys, bye बच्चे. God bless you all. Good night. यार अगर INI CET का रिजल्ट आता है ना, मुझे भी बता देना, ठीक है?